Good afternoon, everyone. Welcome to the HousingLIN Cymru Happy Hour. I'm Joanne Kirrane, Chair of HousingLIN Cymru. You may notice that Jaime, HousingLIN Chief Exec, isn't here today, but as Sally's already introduced herself, I'm sure many of you will know Sally from the HousingLIN team. So, in support of Mental Health Awareness Week, we'll be spending the next hour focusing on the relationship between mental health and well-being and the home. So increasingly, we are seeing more people experiencing periods of poor mental health and well-being, and this calls for a change in the way that we respond. It requires a shift in medical and social models of support that place people at the centre of all that we do. It requires greater collaboration across a whole range of sectors and services to really leave a change. And it means easy access to services and support through place-based delivery, technology and design. And it means that home and community should act as enablers to good mental health and well-being. So I'd like to say a huge thank you to our speakers today. Without you and the fabulous HousingLIN team, events like this would not be possible. We do try to fit in an awful lot into these sessions, and the Q&A session is tight, but please do post questions in the Q&A box, as Sally said. And if we can't respond to all of the questions, some of our speakers have said that they'll do a follow-up blog to respond, if that would be helpful. So moving on, I'm really pleased to welcome our keynote speaker today, Dr. Chris O'Connor. Chris is the clinical lead for the Strategic Programme for Mental Health in the NHS Wales Executive. So welcome, Chris, and over to you for the big picture and how this is changing and will continue to change local services.
Many thanks, Joanne. And Prynhawn, colleagues, really lovely to be with you this afternoon. Thank you for asking me to join you. So as Joanne mentioned, my name is Chris O'Connor. By background, I'm a consultant clinical psychologist, and I'm currently working as a clinical lead in the Strategic Programme for Mental Health, which sits within NHS Performance and Improvement. The task for me this afternoon, within the 8 to 10 minutes I've got, is to try and provide a quick overview of the new open access mental health support model that is being implemented across Wales. Sally, if we could go to the next slide, please. Thank you. So 3 things I'm hoping to do in the next sort of 10 minutes, really. One, just to give the overview of the ambition set out in the Welsh Government Mental Health and Wellbeing Strategy regarding the provision of mental health services. Just a quick reminder, I guess, in terms of Joanne's already touched on this really, about why we need to be doing things differently moving forward, and then to provide an overview of the new open access mental health support model that we are starting to implement across Wales. Next slide, please, Sally. So colleagues will be aware, last spring, so just over 12 months ago, Welsh Government launched its 10-year mental health and wellbeing strategy, a really ambitious all-age strategy in terms of thinking about how we support the mental health and wellbeing of our population. Within that strategy, there's a number of what is described as vision statements. So vision statement 4 is the one that I'm going to be focusing on this afternoon, really largely focuses on the provision of mental health services. So a very clear ambition that our mental health services in the future need to be person-centred, needs-led, with individuals being guided to the right support first time without delay. Obviously need to really acknowledge those mental health services need to be part of a much broader connected system, and ensuring those mental health services are delivering high quality, equitable access, experiences and outcomes for our population. Next slide, please, Sally. So in terms of the current context, many colleagues on today's call will recognise, I guess, many of the challenges that I've described in this single slide. So we're seeing increasing numbers of people, not just in Wales, across the UK and other developed countries, seeking additional support in terms of their mental health. So great that people are coming forward, but it actually, I guess the challenge of that is what we're seeing is demand for services is significantly outstripping supply. And that's right across our mental health system, whether that's within the primary care space, whether that's within our secondary care mental health services. We're facing significant workforce challenges, so both in terms of vacancies, but also in terms of the experience of staff who are working within the mental health system at this point in time. You will be very familiar with the funding challenges that we're currently experiencing, and access for people is a very significant challenge. So we have far too many people waiting far too long to access timely support for their mental health. Within Wales, unfortunately, over many decades, we've had very little investment in either our estates, whether that's in our community estates or whether that's our inpatient facilities, and also little investment in terms of digital infrastructure to support the delivery of high quality mental health care. And I guess what all of those challenges mean for us is despite there being some fantastic practice, what we don't have at this point in time is high quality outcomes experience and timely access for people across Wales consistently. So those are the challenges that we are currently facing. Sally, if we could go to the next couple of slides, please. Um, so I won't go through these, but there's a couple of slides that I've included that people will be able to see after today's event, which just gives some of that evidence around, the increasing numbers of individuals who are experiencing mental health difficulties. So if we could go to the next slide as well, Sally, and the next slide, please. And I guess really just pulling out this as another reason in terms of why we need to do things differently. If we really listen to people who are accessing support or trying to access support and their families and carers, there's a very clear need for us to do things differently for people. So we'll often hear stories, and you will hear stories of people who are either having delayed or inappropriate or inadequate responses, not in a timely way, people potentially not having personalised support, potentially people being referred between services and falling through gaps, and a really strong voice from people with lived experience that we need to do things significantly differently to improve outcomes and experiences for our population across Wales. Next slide, please, Sally. So the challenge for us really is, given those challenges on the left-hand side that I've just mentioned, really, how do we actually deliver that vision that we want to be delivering by the end of the current strategy? So how do we move towards providing those person-centred, needs-led services for people with easy access without delay? Next slide, please, Sally. And that's really where the work that we've been focusing probably over the last 18 months has been progressing, really. So a number of my colleagues and health board colleagues about 18 months ago had an opportunity to engage in some international learning. And that's where they came across what we learned initially about the stepped care 2.0 model. So initially developed within Canada, and so many services and provinces within Canada have implemented that stepped care 2.0 model. But increasingly over recent years, other areas across the world have been moving towards implementing the stepped care 2.0 model. Probably just worth noting from a language perspective, within Wales, we made a decision fairly early on that we weren't going to call it Stepped Care 2.0. That wasn't very meaningful for people, doesn't make much sense for individuals. So really shifting to what we're describing as an open access mental health support model to meet the needs of the population. Next slide, please, Sally. I'll miss that one. Next slide, please. Okay, and really, I guess what this tries to show is, though many people will be familiar with the idea of stepped care models within mental health, and this slide tries to demonstrate how this open access stepped care model is very different to other models people will have previously heard about. So the open access model, decision making about the individual support is very much based on what the person feels ready to engage with and what they wish to engage with. So ensuring that individuals have significant choice in terms of support they access. Not only what support they access, but also how they access support. So for some people that might be face-to-face, for some people that might be digitally, for some people that may be through telephone or other mechanisms. So that's a real shift to compare to previous stepped care models. Next slide, please, Sally. In terms of understanding the model, I guess the way that I like to see it as it provides a really helpful framework for you to think about how you can meet the mental health needs of your population. And within the model, there are three broad areas that help you understand the overall model. So the first part on the left-hand side of this slide is what we describe as the guiding principles that underpin the model. The second area is what we would describe as the core components. And that really is helping you start thinking about how you start putting some of those guiding principles actually into practice, into reality. And then the third part of the model is what is sometimes described as the planning framework or the continuum of care. And that really is about starting to articulate what is the range of support that needs to be available in order to meet the needs of your population. So I'm going to touch on each of those three areas really briefly in the latter part of this presentation. Next slide, please, Sally. So in terms of the guiding principles, really, really important to underpin, I guess, the way that the model moves forward and how people embrace the model. And there's some, all of these are really, really important things, but it talks to a number of areas. One about absolutely is a strength-based model. So really making sure and acknowledging that all individuals and communities have strengths and capacity that we can build on. A real shift to actually saying that professionals don't carry all the wisdom. So often having a conversation with an individual, that individual will know what is best for them and will be able to articulate what is going to be most helpful for them. A real shift to saying that we need to have multiple and diverse care options available for people, as we know that one approach isn't going to work for everyone. Also, this idea around, a minimal intervention can produce an incredibly powerful result. So we know actually a really powerful one at a time conversation, one at a time intervention can be incredibly helpful for somebody at that point in time if they get that when they need it. And I guess another principle around here is around saying that part of this is around acknowledging there's no ideal solution. And actually, the way that we transform services and systems often needs to be based on a bit of a trial and error approach where we actually try things out, have really clear evaluation and learning around them to inform what is the next iteration of those. And that can really lead to growth and positive change. Next slide, please, Sally. So the second part of the model is what I was describing as those core components, and these sort of go into two broad areas. On the left-hand side are the core components that would be described as the things that can support system redesign. So some of the ways and approaches that you want to use in order to transform our mental health system moving forward. So just a couple of examples there around making sure that any transformation that we take forward is really co-designed with people holding diverse perspectives. So people with lived and living experience, their families, their carers, and also the broader range of stakeholders contributing to what that model needs to look like moving forward. Moving to thinking around safety and thinking about how we ensure that safety is distributed across the system. So it doesn't sit with any particular individual who often feels, and I know from speaking to housing colleagues in the past, can often feel quite isolated and feeling they're holding a whole load of safety issues. So actually, how do we move that so it's more distributed across the system? The idea about continuous learning and quality improvement in the way that we implement the new model, and ensuring the model is consistently recovery orientated and trauma informed, underpinning the whole model of how we move forward. And then the right-hand side of this is around the core components that support people's experiences. So the one area is around open access to same-day support for people, so people not needing to wait and people not needing to be put on referral pathways. That if you want support that day, a way for you to be able to access that. I've mentioned the one at a time approach, so really maximizing and making sure that every single conversation that we have with a person is helpful at that point in time for people. And then making sure that services are flexible, data informed, and that our care is person centered and collaborative. Next slide, please, Sally. I'm going to whiz through these because I'm mindful that my 10 minutes is coming towards an end. So just when I'm very happy for these slides to be shared with colleagues after the event. So there's just a little bit of more detail on the slides in relation to some of those individual core components. So there's a little bit more detail in relation to what we mean by the open access model on that slide. Next slide, please, Sally. This slide talks a little bit about in terms of that one at a time approach and the benefits of implementing a one at a time approach. Next slide, please, Sally. And then the third part of the model that I talked about was that idea about the planning framework. So ensuring that there are multiple and diverse care options available for everybody, because not one thing will work for everybody. So if we move to the next slide, what the model articulates is, in order to meet the needs of your population, you need to be offering support in all of these areas. So right from really high quality self-help information to people, to a really high quality peer support offer for everybody across Wales, through to psychoeducational courses be available in people's communities, guided self-help, group interventions, individual interventions, and then more what you'd probably get from more specialist mental health services. So really ensuring that range of offer needs to be available for people, and about people choosing about which bit they want to engage with. So it's not about professionals prescribing it. It's about a meaningful conversation with somebody around which is going to be most helpful for you at this point in time. Which of these things would you like to try and engage with? And as much as possible, making sure that that continuum of care is open access for people, so they don't need to go through referral systems for that. Next slide, please, Sally. I'm really mindful I'm running out of time. One of the bits of feedback we've had from colleagues is that people don't like it presented in a stepped model. It actually is really quite misleading. So these are some examples of other services across the world who have, for example, described the model in terms of putting the person and their family at the centre, and then the offer of support is around in that circle around the outside. We're doing some work in the moment with how we're going to present that for us within Wales. Next slide, please, Sally. In terms of evaluation of the model, so and can provide references for people after today, but I guess what we have learned from those services who have implemented the model, there are very positive feedback in terms of people experience of accessing support through this model. So next slide, please, Sally. People talk about, and there are improvements in people's rated clinical outcomes and also people's rating of their own well-being. Next slide, please, Sally. And also from a staff perspective, so staff reporting increasing professional satisfaction and reduced workload management challenges if they're working in this model. Thanks, Sally. Next slide. And the last thing, I guess, in terms of the evaluation is that people have been thinking about from a system impact, what are some of those benefits for the broader system by implementing such a model? So there's a pretty comprehensive evaluation framework to support the model. Next slide, please, Sally. And then, and I'm not going to mention this at all today, I guess the last 12 months though that we've been focusing on really is in Wales, is thinking about how do we build readiness and prepare for success for implementing this model across Wales. Often we have really good ideas within Wales, but often our challenge can be around actually how do we put that into practice. So we're really trying to take the approaches of implementation science and implementation practice to really support us in terms of how we move forward and embed the model across Wales. So most of the work over the last 12 months has been around building that readiness and preparing for success. And as we go into this financial year, we'll be focusing now on more of the implementation of the model. Okay, thanks, Sally. Next slide. And I guess for me, probably just some areas to reflect on really is I'm really interested from your perspective around how will implementation of this model support the delivery of your key strategic priorities from a housing perspective. In what ways are you already working within housing that supports delivery of this open access support model? And finally, I guess thinking about what opportunities does the model provide for us to have greater collaboration between housing and mental health services to improve the mental health and wellbeing of our population. So thank you very much, colleagues. I'm mindful I've talked to people very quickly, but hope that gives an overview of the model. Thank you.
Thank you very much, Chris. That was a huge amount of information in a very short space of time, but it was really good to hear about the ambitions for mental health services in Wales and the approach that you shared around whole system change, and good to see those early positive outcomes as well. So thank you for agreeing to share the slides. And I think when we come into the Q&A session later, we'll pick up on the opportunity to share reflections. Okay, so we've seen and heard about the big picture. Our next two speakers will really shift that focus to people and day-to-day service delivery and practice. So I'm really pleased to introduce Jaime Devine from Mind to share his people first story. So over to you, Jaime.
Oh, thank you, Joanne. Prynhawn da pawb. Let me just share my screen. Can anyone see that okay? Yep, okay, thank you. So this afternoon I'll be speaking about trauma-informed and person-centered approaches that can help prevent tenancy breakdown for people experiencing poor mental health. I will be focusing on how early intervention not only benefits the individual, but also reduces pressure on both statutory and non-statutory services. Mental health and housing are closely connected where tenancy breakdown really happens suddenly. There is a clear link between unstable housing, financial insecurity, and poor mental health. There are usually early warning signs such as tenant withdrawal, missing rent payments, deterioration of property conditions, and presentations. If signs are missed, situations can escalate quickly into crisis, leading to eviction, homelessness, or the need for intensive support. A prevention-focused approach allows us to intervene earlier, promoting stability to keep people in their homes and support their recovery. A trauma-informed approach is essential to early intervention. It helps us understand that behaviours like disengagement or avoidance are often responses to past experiences or feeling overwhelmed, not simply a lack of willingness. By recognising this early, we can respond with empathy and build trust rather than unintentionally escalating a situation. Alongside the trauma-informed approach, person-centred support ensures that we are working with individuals and not just addressing the problems. It allows us to tailor support based on what matters to the individual, whether it is managing finances, improving their well-being, or simply feeling more in control. Sorry about that. Sorry, there we go. Okay. There are several common early indicators that a tenancy may become at risk. As previously mentioned, these may include isolation and withdrawal, deterioration in condition and upkeep of tenancy. Some individuals may also become more vulnerable to unhealthy coping strategies such as increased or excessive alcohol or substance usage. It is important to recognise that these are not just problems but opportunities for intervention, a chance to support the tenant at their point of need, and there is a chance that with help they can take back ownership and control of their own lives. So what does this look like in practice? It means by being proactive, engaging early in building trust and addressing small issues before they grow. A reduction in the number of different staff engaging with tenants or individuals will help professional relationships develop based on trust and respect. With this trust, goal setting can be discussed and implemented with a focus on doing with and not doing for. An example, supporting someone to open and respond to letters early can prevent rent arrears. Helping someone build a simple routine can help reduce feelings of feeling overwhelmed, and small consistent actions can make significant differences over time. Tools such as a tenancy workbook, as developed by Mind and Gwent, can play an important role here. As a working document, it provides structured, practical support to tenants that aid in the building of skills and confidence early, before problems reach crisis point. They also give support workers and other support in place a consistent framework to guide conversations and interventions. The workbooks contain information around budgeting skills, tenancy understanding, home management, and wellbeing integration. Part of the books, although they focus primarily on practical activities, do address poor mental health and what to do when somebody's feeling unwell and those first stages. Sometimes those are hard to recognize, and it's good to have those written down in a document that the tenant or the client keeps and work with that going through. Providing support early for adults with poor mental health is far more effective and much cheaper than waiting until someone reaches crisis point or loses their tenancy. Early help such as tenancy support alongside early mental health intervention and regular wellbeing checks can prevent homelessness, reduce hospital admissions, and lower involvement with emergency and criminal justice services. UK research carried out by Crisis shows that preventing homelessness can cost as little as £1,426 per person, compared with over the £20,000 when someone ends up sleeping rough for a year. People facing homelessness also place greater demand on NHS and mental health services, as well as temporary accommodation and policing. Investing in early support not only helps people stay safe and stable in their homes, but also saves significant public money in the long term. So the key takeaways here are early signs matter. Early intervention and prevention is much more effective than crisis management, something I believe that Chris reflected on earlier. Relationships enable success. We find as an organisation, we work with just under 500 people across the county. During the 11 years that we've been providing housing support in Newport, we've only ever had to evict one member of the one tenant from our accommodation. So that's a very high success rate, and I believe that's mainly around our trauma-informed and person-centred approach. And empowerment that sustains tenancies. So giving control to the individual helps with that. So that's me. Thank you very much. Back over to you, Joanne. Thank you.
Oh, that's great. Thanks very much, Jaime. One of the points I picked up was that you mentioned was the early signs, and they're absolutely key, but often missed or masked, aren't they? And it's often about the right support being available at the right place and the right time. Which does link with Chris's presentation, but it also leads us nicely on to our next speaker. So I'm really pleased to welcome Lynda Williams from Clwyd Allen, who's going to showcase best practice in accessible service provision in Rhyl. Over to you, Lynda.
Thank you. Good afternoon, everyone. Yeah, as I say, I work for Clwyd Allen Housing. We're a social landlord across North Wales with 7,000 homes. We also have a range of different services, homeless services, and we also host the iCAN hub, which is what I'm going to speak about today. So iCAN first started in 3 A&E departments a few years ago within the North Wales area, and it was run by volunteers. The aim of the hub was for anybody presenting to A&E with mental health issues, they would be triaged to the hub and they would speak to the volunteers to try and alleviate any concerns and to reduce the demand on A&E, which is still significant today. Unfortunately, with the pandemic, the hubs within hospitals closed and they haven't reopened. In 2019, it was identified that there was a demand on services in Rhyl, and with Rhyl sadly being an area of deprivation in 2025, one of the areas of deprivation, it was discussed that we needed to have a community service, open access, where anybody within the Denbighshire area, specifically Rhyl community, could access in the event of any type of social crisis. The hub opened, let's say, in 2020, just before we went into lockdown. We did remain open. It's hosted in partnership with Betsy Cadwallader Health Board. And the aim of it is a safe space for anybody in the community who are in social crisis and require a social response rather than a clinical response. The hub is open 7 days a week, 10 until 7 p.m. We have 3 members of staff at the hub. There is a referral process, but there is also a drop-in available, so anybody can drop in at any time. We also have activity groups in the hub that are run on a regular basis. The aim of the hub, as I say, is now to align with the Wales mental health strategy regarding the open access and no wrong door. And obviously we want people in Wales to live in communities that support their mental health and well-being. In the last 12 months, apologies. Can I go to the next slide? I'm getting carried away and I've asked, can we move to the next slide again? Apologies. Thank you. So yeah, I've just spoke about that, what we do 7 days a week. Next slide, please. Okay, so in the last 12 months, 1,690 people have accessed the hub. 54% of the people accessing the hub are in employment. The top 3 reasons for people accessing, and this is just relating to Rhyl service, is housing issues, isolation, and mental health and well-being. The hub works with a range of organisations in Rhyl and across Denbighshire to provide person-centred support. Obviously, Citizens Advice, Local Authority, North Wales Police, to name a few. I won't list them, but you can see on the slides. I'm also happy to share these, the range of services that we work with. We work really closely with local GPs and also community mental health services, as well as hospitals. There are actually 14 hubs across North Wales. So there's 2 in Denbighshire, but the hubs are dispersed from Anglesey over to Wrexham. And there is a plan to look at increasing those hubs over the coming year. Next slide, please. So as you can see, the figures from the 1st of April up until the 31st of March. So the stats have recently been done by the team. A slight decrease this year, 1,690 compared to the year before, 1,753 people accessing. I won't go into all the detail on the slides, but as you can see, there's really high numbers of people accessing, with 1,123 people in the last year receiving one-to-one support and 509 people receiving intensive support. When we say intensive support, what that often means is 3 to 4 visits every week face-to-face. So people are dropping into the hub for support 3 to 4 times a week, up to an hour and a half at a time. So we would class that as quite intensive support. We've also had 221 people that have joined activity groups over the last year. We also look at what their achievements are with the Warwick-Edinburgh model, which is the wellbeing model. And as you can see, we've got 81% of people achieving their personal outcomes, 77% feeling less isolated. Obviously there's some high numbers there, but the percentage is 87% feel that they're more able to deal with their problems well. And 92% of people over the last 12 months have reported that they're maintaining and they're improving their emotional health and well-being. Next slide, please. So this is just some feedback from residents and, as I said, from clients. I won't go into detail about. I won't read it all, but we have some really fantastic case studies and feedback, and there's times where we work with a range of people, and when they come to us, they're often in that much crisis that they don't see a way out. And just one of them, I'll just briefly go over it. After losing my wife, I didn't want to carry on. With the support from the fire service, ambulance and police who saved my life, referrals were made to social services and iCAN, where I received help and support to get my home to a habitable condition. I'm enjoying my life and learning to live with grief. iCAN gave me a reason to keep going, and I've started my artwork again, which has been therapy for me. So this is just one of the many testimonials that we receive from clients who remain with us and have moved on, and we try and keep we don't keep people on the books for that long if we can help it, because we understand that there's a huge demand on service. We don't have a waiting list, but if often people will come in crisis, within 2 to 3 visits and follow-ups and signposting, they often feel that they're in a place where they can support themselves, or they might not need that intensive support. So it is very much person-centred, and services, we adapt services to suit the needs of individuals. I think just to touch on as well, and apologies, I didn't put this in a slide, but just over the next year, the iCAN, they're looking, the hubs across all of North Wales are obviously wanting to work to align with the new mental health strategy. We're also looking at peer-led services and people with lived experience to be involved in decision-making and the delivery of the service. That's really important, and I think it's important not only to Clwyd Allen, but also to the Health Board. The aim is to have longer-term funding. At the moment, we have funding year on year, and with short-term funding, that can often cause pressures with regards to staffing, but also uncertainty with clients who access the service about whether the service will continue. So we have campaigned for more longer-term funding. And obviously, the biggest one is to have more hubs across not only North Wales, but the whole of Wales as well. Next slide, please. Oh, I think that is it from me. Quite short and sweet to give you just a brief overview of the work that we do in Rhyl, but obviously what the hubs do across the whole of North Wales. And I'm happy to answer any questions. Thank you very much.
Oh, thank you, Lynda. The hub sounds brilliant, and you shared some really powerful quotes there, and I'm sure other areas in Wales will be very envious of the model that you've got, which is clearly having an impact. So just a reminder to people on the call, if you've got any questions, do put them in the Q&A box, and we will be picking those up after our our next presentation. So I'm really pleased to welcome our final speakers of the afternoon, Gemma Thomas from Public Health Team in Aneurin Bevan University Health Board, and Ben Roberts, the founder and CEO of Tenants Hub AI. Over to you.
Are you all sharing Gemma's presentation, I think, for us? Is that right?
Yes, yeah, I'll get those up on screen now for you.
Yeah, it's just some food. Good afternoon, all. We're going to be presenting on transforming health and housing pathways using AI. I'm Gemma Thomas. I'm a public health practitioner in the Aneurin Bevan Health Board, and this is Ben Roberts, CEO of Tenants Hub AI. Next slide, please. So where this project has originated from, Ben and myself were both successful applicants on the Infuse project, which is a Cardiff Capital Region funded project. It started in April 2026 and it completes in July 2026. And the aim of the project is to see how we can use AI to transform public services for all. Our focus is around housing and homelessness, and experimenting with different AI projects to see how we can transform and make referrals simpler. Over 12 weeks, our teams were tasked with designing an AI-driven solution. And the one that we are looking at includes referral, prevention, data sharing, and early intervention. At the end of the 12-week programme, there's the opportunity to bid for a share of £500,000 to progress this project into full development and implementation. The next slide. So our project will be a health and housing referral portal. And I'd just like to give you a little bit of background and rationale for this portal. Next slide, please. So I conducted a Gwent-wide health and housing assessment, which started in January and was completed in April. Throughout this process, I engaged with over 100 stakeholders in one-to-one interviews and questionnaires. And throughout all of I engaged with secondary care, local authority teams, adult services, mental health, OTs, and third sector partners such as Care and Repair, Citizens Advice. And it became really clear that there were examples of good partnership working, but also that there was gaps. And there was a need for a current referral system which was standardised throughout Gwent. There was a clear opportunity to create a unified, user-friendly and scalable AI solution to support housing referrals and early intervention. Our project aims to better support ageing populations, people with mental health needs, and improve overall well-being by strengthening access to safe, suitable housing. The next slide. So some of the key issues that were identified was there was no single standardised referral pathways. Each local authority uses a different system and there's no interplay between these. GPs and hospital discharge teams were unsure which pathway to use, and then this meant to referrals being delayed or referrals not being made. Care navigators relied heavily on local knowledge and there was no shared system or mapped pathways for each local authority. Many referrals relied on knowing the right person, and then when staff left, these referral routes broke down. They were often by email and really informal. There's no formal mechanism for shared learning or service updates. Once referrals were made, staff weren't receiving notification as to whether these had been successful or any delays. There was no feedback mechanism built into the referral routes. As a result, adaptations were delayed due to unclear referral routes, and housing teams were often notified too late to prevent delayed discharge. So people were being discharged from hospital without the housing association being notified or without the adaptations being made, which meant they were in unsuitable accommodation. So there was a clear need identified for this standard referral portal supported by AI. This is where Ben comes in. So he's going to explain.
Hi. Sorry.
No.
Hi. So I'm So I work with Tenants Hub AI. We're working with the councils in England and Wales, including Birmingham Council, and we have an app which heavily uses AI and helps save around 10% of the cost of housing repairs. What we're doing is we're building on the current technology we have with this portal with Gemma. So I'm just going to show you how we currently work and the prototypes for the work with Gemma. So some sort of first thing, to share the video. I can share the screen from here, right? All right.
Yeah.
Is that right? Can we see that? Yeah. Allow.
Yes, I can see that.
Okay, so quickly I'm going to show you how we connect tenants to housing associations and how we use AI to translate between English and Welsh in real time and to analyse problems.
Just so you know, I don't think we've got sound on that video on our end, but we can see
Oh,
it.
okay, let me just do it then. Okay. Sorry, guys. So you can hear me though, right?
Yes, yeah.
Okay, I'll just do this. It's got, okay, so if you look on the left, we're looking for the point of someone who, an administrator in a housing authority. If we're looking on the right, we're looking for the point of view of a tenant. So if I'm a tenant in a property, I can now take a picture of a problem in my property, upload that picture, and hit analyze fault. The AI will automatically tell me what the type of problem is, how urgent it is, and then I can submit that. If you look on the left, when I submit that, it goes straight to the dashboard of the person running the housing association. Now, in the case that you have a tenant that speaks a different language, and we can translate from any language, but in this case, we're looking at Welsh. We're going to select Welsh from the language portal, language settings even, go back to the fault. It's already translated in Welsh. Now we're going to see that it translates the text into Welsh. And then if we look, if I want to send another message on the left, which I can send in English, I can't remember which side we're sending. So it translates it on. If you look on the right, it translates into Welsh. And if I send a message in English, it pops up on the right for the Welsh and translates again to Welsh. So building on this technology that we already use to heavily leverage AI, we're now working on a new system which again can use the same systems to do translation, and we're using it for a tenant referral portal. So let's have a look. So you see this new screen?
Yes, we can.
Okay, thank you. So what we're imagining is if you're a nurse, or I mean, this can be applied to a lot of different people in mental health or in prisons. If you've got somebody that's going to enter your institution, say a hospital, you can, when they enter the institution, you can put in their details, or you can load those details from their patient records. Then you can select the type of problem they have, or the type of issue they have. So namely, the type of accommodation they have even, sorry, this is a new thing. When you select that, you can add the type of physical issue that they have. So that can be physical adaptation required, such as rails, if someone's had a fall, or if there's a need for mental health. You can add some notes. You can then upload any supporting documents. And then we can use our analysis of this data to give a patient summary, give your notes, and then automatically assign them to the correct local authority and to the correct type of mental health teams, or whatever team, depending on the requirement. Because I understand from what Gemma is saying, often you have that problem of someone entering a hospital, but not having being prepared for when they exit. They can then end up staying far too long, of course, and that can be very costly. So by using a system like this, what we do, let's go back to the beginning, we can select a different type of their problem as soon as they enter the property, allow us to automatically select the types of services they want to send that help for, and alert those referral teams by just doing that. Additionally, we have a dashboard so that you can understand the amount of time, amount of beds you would have saved, the amount of referrals made, and that's useful in the hospital.
Absolutely. So what we would like is that conversations are happening as soon as the patient enters hospital. So within the first 24 hours, a conversation is being had about their housing situation. If they are homeless, if they need a physical adaptation, say they've had a stroke and they need handrails fitted, and then this referral is automatically done to the appropriate referral organisation or local authority. As we know, there's differences whether the person is a private homeowner or if they're in a housing association. With this AI system embedded, this will automatically do that referral, but also it will give that feedback loop. So the nurse who has sent off the referral will get a notification of when the referral has been received and the status of update. So how long roughly they can estimate then how long the person will be in hospital. The hope then is this will give us cost savings as we're able to support early discharge. And on average, it costs at the moment for a hospital bed £300 per day. So if we can get more efficient referrals and earlier discharge, this will be a massive cost saving to the NHS. This system, we've started basing it on primary and secondary care referrals from the hospital and the GP practice. What we would like to do is develop this referral portal so it can be accessed by the job centre, it can be accessed by the prison service when somebody is leaving, it can be accessed by citizens' advice. It will look slightly different, but it will still allow the same referral processes and show them a dashboard then letting them know how the referrals are being processed. This is very much a programme that's in development. We would welcome any feedback, any questions that you have, and we want it to be a system that's user-friendly and works really for frontline staff. So any feedback that you have would be welcomed as we continue to develop the portal. And thank you so much for your time.
Thank you very much.
Oh, thank you very much, both. I didn't know what to expect. I didn't see your presentation beforehand, so it was very interesting. Thank you. Interesting, Gemma, you really described a fragmented health, social care, and housing system as a wider system. I don't think that will come as a huge surprise to people on the call. And my ears just really pricked up when I heard that when people come into hospital, a very early conversation about housing and the home. Because I know my own experience within my day-to-day role is that when that doesn't consistently happen, it's not good for the individual, it's not good for the service user, and it obviously has implications for the health service or other organisations. So thank you very much. Okay, well that's our presentations over. So we've got, oh, I was about to say 11 minutes. We've got 10 minutes. We've stuck to time. This has never happened before. Thank you. So if we have a look in the Q&A box, there's only one question there. I did see a query in the chat about the recording, so we can respond to that separately. I have got a couple of questions. I've been writing things down as you've been speaking. So if we just go to the Q&A box, does the translation cover other languages, and does it offer a talk and hear option?
Well, it covers any language. So we're in Scotland demonstrating this in Glasgow, and we tried it with Ukrainian even, and it worked live with Ukrainian. You can also do a push to talk thing. I didn't have a lot of time to show you all the other things we do with AI. I just want to give you a sort of a flavor of what's available now and how we're using it and how we can just save so much time with communication. And yes, you can do a push to talk. It translates as you talk and records text, and then you can do that to just as easily. And that's quite simple to do now, actually.
That's quite impressive. Thank you. Well, in the absence of any other questions, or if some more appear while I'm asking my questions, can I come to you first, please, Chris? I'm interested in the messaging around the open access model. So I became aware of it through a chance conversation. And then we linked up, Chris, and that was great. So yeah, how is it being communicated? Because clearly there are lots of stakeholders in the model that you've described.
Yeah, Joanne, I think to be open, it's a real challenge to think about how we do maximise that engagement and talking to as many people as possible about the model. So there is a comms and engagement plan to support the implementation of the model. And that includes some of the sort of typical things that you would expect in terms of newsletters, webinar series, etc. So I could make sure that was available for people afterwards if they wanted to join up to any of those things. We're also doing a particular piece of work at the moment in terms of trying to think about what is a visualization and some animations of the model that can really describe it for people who are trying to access support in a very clear, friendly way. So that's a piece of work that's ongoing. But I think for me, there's something is about how we continue to build relationships with stakeholders right across the system as we move forward. And I think for me, that's informal and formal stuff. So I think we need to be thinking more around how do we use the mechanisms like regional partnership boards, public service boards, but also opportunities like this. So those would be some things I was thinking about. But equally, really welcome any ideas and thoughts about what else we can be doing to strengthen it as we move forward.
Okay, no, well, you give people like us an invitation to think about things and come back to you, and we will. I am conscious of time, but I know that you posed a few areas for reflection, and you will be sharing your presentation. How can members on this webinar provide feedback to you on those reflection points?
Yeah. Probably the simplest thing in terms of just thinking really practically, at the front of my presentation, I've got my email address. So would really welcome people just, responding, any thoughts, reflections, that would be fab.
Okay,
Really welcome.
that's great. Thank you. Thanks very much, Chris. I've just seen another question from Stephen Thomas. Working Home Repair, an older person's housing adaptations charity, largely support owner-occupiers or PRS tenants, and we also support hospital discharge through Hospital to a Healthier Home. Is the intention for the AI model to support owner-occupier and PRS tenants or predominantly social housing? That's one for Jem and Ben.
It would be both. That is the problem, the complexity of, if you're a private homeowner or social housing, and then for the discharge team to try and navigate where they go. So the AI system would be for both. It'd be for any tenant and any local authority. We're focusing the initial project on Gwent and the 5 local authorities in Gwent, but we want this to be scalable, so it could be across all 5 local authorities and private tenants, private homeowners, and social tenants as well.
The idea is any person that comes into your hospital facility, one of the considerations is how can we, ensure that they are not homeless when they leave. So the idea is as soon as they come in, we enter them into the system can advise the right types of charities or response depending on their type of problem. Because one of the real issues, which Gemma has explained to me, is that the person who's doing the discharge or entering doesn't know who to contact. So behind this front end system, which is quite straightforward, really, it's just sending a message, will be a back end system which we manage by someone like Gemma or yourselves, in which you go, okay, this type of person, connect them with this charity or connect them with these different services. So it's a much kind of wider thing. We aim to support all types.
Okay, no, that's good news. Thank you. Jaime, can I come to you, please? So prevention and early intervention is absolutely key, and that came across really clearly in your presentation. But what challenges do you experience when escalation is required, but a case might not hit the traditional thresholds of another service? And so a gap's created, which could essentially lead to an escalation of a crisis, which could be avoided. So do you have that experience?
Yeah, for ourselves, I'm sure that many others will feel the same way. This normally happens when you are looking at tenants with co-occurring needs, so they fall between sectors. You might have mental health and then a substance misuse, and there seems to be a disparity or a gap within services coming together, and that's a major issue for us as an organisation. I would say that out of the 56 tenants that we have and over 400 that we support every week, approximately 70 to 74% of those have some form of co-occurring need outside of mental health, mainly drug and alcohol usage. And we do tend to find that there are difficulties in getting statutory services engaged. We do engage with other third sector organisations such as ABSDAS and GDAS, and then we also engage with ABSDAS. But there is, if somebody does start slipping into crisis, there is a lag in support being picked up going forward. So those are the areas that we are finding difficult at this moment in time.
It's a challenge I hear regularly, that where people could essentially fall through a gap. And hopefully, just listening to the discussions that we've had today, and Chris, we're pinning an awful lot on this new model. There's just nothing in it that I could argue with. But it's about understanding that whole system change and the time it takes to create that shift into everybody's day-to-day practice. Thanks.
I feel quite sorry, Joe. Yeah, I feel quite positive about Chris's presentation today in relation to the very person-centered, and it's what that person needs at that particular time, and that's something that is worth exploring further. Thank you.
Absolutely. Can I come to you now, Lynda? This isn't too taxing. I was really impressed, really impressed with what's going on in North Wales. And you did mention that you've got 14 hubs and plans to increase. And you also kind of talked about that powerful impact. So how could this be scaled up? You did say that, there's potential for it to extend into other parts of Wales. But could it be replicated, and how could that happen?
Being absolutely replicated. I think what the Betsy Cadwallader have just finished a huge piece of work across the hubs, reviewing the hubs, looking at what the hub, how it aligns with the mental health strategy, because obviously the hubs run very differently, but the need for evening opening times and weekend opening times is absolutely crucial. So there's a piece of work that's been ongoing, and a report is due out within, I think, by the end of June, with how Betsy Cadwallader Health Board are going to work with the partner agencies to look at potentially upscaling, increasing the hubs across North Wales. And if it can happen in North Wales, for me, it should happen across the whole of Wales. What we should be able to mirror great practice in one area, and we should be able to mirror that in other areas of Wales. So I'm hopeful. Things take time, unfortunately, with funding and reviews that have to happen. But there is a big piece of work going on at the moment to review the hubs and look at how we can increase, because we understand the demand for the hub is exceptionally high, with some hubs having waiting lists of up to 4 weeks. We're very lucky that we don't have waiting lists in Rhyl because of the hours we work and the 7-day opening offer, which has been very favourable, to the community of Rhyl and Denbighshire.
No, I can't remember the exact statistic. Was it 54% or in employment? And there are still an awful lot of services that are fixed around 9 to 5, Monday to Friday. And just what a difference that accessible model makes. We are at our full time. Can I just ask, I won't be upset if people leave, but I've got one quick question, and I don't think there'll be a quick answer, so we'll need it as timely as possible. And this goes to Gemma and Ben, and I'm sorry for being the person that asks, but data sharing protocols, I could kind of understand it at first. I thought, okay, we've got some well-trodden paths between parts of services, but then when you started bringing in the opportunity for job centres, etc., I thought, okay, I'm lost here.
It is obviously a major concern of ours about the ability to share data. Now, if a different types of user wants to go onto the system, whether it's someone in a nurse or someone in a job centre, where they would have a different login and different rights to different access. So a nurse obviously would have access to the NHS information, but of course, if you're working in a job centre, you wouldn't have that information at all. And of course, there's that ability to type or drag in documents that our AI can analyze when you don't have that, but you're with the person and they're saying, okay, this is where I live and here's my information. So we're very aware that perhaps the biggest challenge of all is to understand what contributes to people's privacy, which is paramount importance, and to ensure that we do not cross that line. One other way we were thinking about approaching this is not having access to the data, but allowing the AI to go and fetch it and just check, do they have accommodation? Or check what's the quality of their accommodation. And then we don't even see the answers. We don't get any of that information because we obviously need to protect these people from, whatever we can. And we just get that. All we need to know is, are they vulnerable and how do we take care of them? And that's all the information we want to share. Thank you.
We will have the opportunity for the person who's receiving the referral to request more data, and it might be a case of a phone call then where we're not on consent from the patient or residents to share their information, but we wouldn't be data sharing online.
Okay, thank you very much. I have just scanned the chat and I can see different linkages have been made in the chat, and that's all kind of gone on in the background. So I'll now bring this to a close. Thank you so much for speaking to our speakers today. Thank you for coming along. Thank you for those of you that have joined the webinar. I hope that there is something for people to take away. Presentations where we've got permission to share, they will be shared soon after by the HousingLIN, and the recording will also be made available. So thanks again. It's great to see you, and have a good week. Thank you.
Thank you all.
Thank you. Thank you.